Let's be honest, modern medicine is broken. Patients are dismissed, doctors are exhausted, and mental health care is decades behind. So it's time to disrupt the status quo, to challenge a system that fragments care, dehumanizes patients, and burns out clinicians. I'm Dr. Georgine Nanos, and this is The Kind Revolution, a podcast about breaking old paradigms, rebuilding medicine with compassion and science, and reimagining what healthcare can be when we finally get it right. Because change is here, and it's starting with us. Welcome to the revolution. Welcome back to The Kind Revolution, where we explore bold ideas, integrative health, and the people transforming the way we care for one another. Today, I'm honored to welcome my dear friend, Dr. Tina Atherall, CEO of PsychArmor, Doctor of Social Work, and a nationally recognized leader in advancing innovative, evidence-informed solutions for military-connected families and communities. Dr. Atherall is an impact-driven executive and leadership coach whose work bridges public-private partnerships, community-based care, and systems-level change. We're going to talk about the intersection of military culture, mental health innovation, and why community, not isolation, may be one of our most powerful healing tools. Welcome, Tina.
Wow, did I love that introduction? Can I have that later? Because that was pretty amazing.
Yeah. Well, you're pretty amazing. I'm
Thank you
so
for that.
happy that we're together talking, because that's what we love to do. Let's start with your personal journey, your kind of origin story and leadership path. What originally drew you to social work and ultimately to leading PsychArmor?
Yeah. So I could dig way, way back to say, like, especially around the conversation around health and healthcare and behavioral health. You know, I've always had a passion for medicine and had thought that my road would have taken me more to a formal medical path, but instead I joined the Marine Corps family, which makes it extremely difficult, though you did it. So that's interesting. But my path went in a different way and really landed on the side of the social service or the human service and social impact side of serving military veterans and their families as a part of being a member of that community. So social work was a really great place to create a foundation that really understood the root of a problem, but the systems level approach. And then my experience working within the military system, the veteran system, and having a family experience provided me a great opportunity to develop as a social worker that had an emphasis and a expertise in military social work. I've been a part of some really awesome community initiatives that started within the nonprofit or the social impact, working alongside communities, government partners, and businesses as they developed out their support, their programs and initiatives, all about supporting our military connected community. So it's been an interesting journey, but social work's been a great framework. The nonprofit is where I say I hang my hat, my auspice, and it's been a great place to build things.
I love it. And you are the most kind of one of the most go-getter, hypercharged, like always creating, always innovating. You have so many great ideas, and tell me, let's talk about some of those initiatives and all these things that we've talked about that may have come to fruition that you're most excited about.
Yeah, I think, one of the things that's really important for me is like, what is the story being told? And is that truly the story for the community? So as we look at this bigger and larger conversation around what are the needs of our military connected or veteran community, there's this instant like transition over to PTSD, mental health. What are we not doing for our veteran community? And I actually see it in a different way. I think it's a larger conversation, one that you've been a part of. And the baseline to that is in any community that we're serving, but in particular for the military connected community, have we asked that community what it was that they're really struggling with or that they see is the problem and how they would like to receive a solution, right? So in particular,
Yeah.
when we think about community approaches, the things that you and I have worked on is like, if we're going to talk about mental health related to the military connected, we'll just put it in that bubble. Like, what is it really that is a mental health or behavioral health concern? We automatically go to PTSD, but when we look at it, it's really a variety of other stressors that are really specific and unique to this community. And if we don't understand what those stressors are, we're going to be off the mark when we're diagnosing or supporting and treating this thing called PTSD, which may or may not be there. I love the breakdown of education that you've done over the years that I've been a part of, because that's kind of what I'm talking about. It's like, how do we say, okay, we have identified through research and we know that there's a problem, but have we really asked the community itself? And so I think when we do that, we get some innovative approaches to actually how we can serve this population and serve them well.
Yeah, I, I totally agree. When you say military connected community, who does that include to you?
Yeah, thanks. Because I it gets tiring to talk. So I think first and foremost, when serving this community, we have to understand there's two different systems of care. Actually, three, because you're in the third. So there's the military, which is active duty, guard, and reserve, and they may or may not sit under this big, huge system called Department of Defense, Department of War, and that system of care, right? And then there's the veterans that sit within the VA system, maybe and maybe not. And then the community that you serve and have done so many great things around, which is community care, even commercial care, right? So not everybody receives their care from VA, and not everybody, like if we're talking about active duty, their family members and their kids may be receiving care out in town, which you are that community provider. So I kind of see it in three different lanes, but it's military, active duty, guard, reserve, their family members, which could be kids, could be extra dependents. And then in the veteran community, could be everything from family members to caregivers. But not everybody is served by the same system of care, which makes it extremely confusing, especially when we make this broad statement about how we should be taking care of this population. If you don't understand the system that is also holding them in place, we're missing the mark.
Yeah, absolutely. I mean, I certainly see that all the time. There is a huge, not only that, but just a disparity in the care and how it's delivered across those communities. What are some of the common misconceptions that providers have when working with veterans or military families that you wish they were better on?
Yeah. So you've worked with Dr. Heidi Kraft, our chief clinical advisor at PsychArmor, and she has really been a foundation of voice for me, in saying you don't know how, you don't have to know everything, but you just need to know how to ask a couple additional questions. So I think one of the biggest misconceptions is just having one baseline of understanding, one, that everyone's a veteran, which is not true. And we miss the mark if we think that just everyone is a veteran. And it's easier when talking to health or behavioral health providers, because we all have a mandate around understanding the cultural competency of those that we serve. So my biggest thing in misconception is saying, if you're hanging up a placard that says, I'm here for the military connected community, which might be that you're taking in insurance that supports them, like TRICARE, right? Or you're a community provider to the VA, you need to have a baseline understanding of just what is the basics to military culture. And that is, from the very beginning, there's multiple branches of service and not everybody's a soldier. You and I understand the context of different branches and their nomenclatures and the pride that goes behind being a Marine, a soldier, a sailor. And when we miss that mark from that immediate area of engagement, those are some misconceptions that I think providers don't understand. It's like you have a few shots to get it right. And when you miss it, that's the type of person that's not going to come back. So bringing the research into this, uh, research through RAND tells us like less than 13% of healthcare providers have any type of cultural training in supporting that military connected community. One of the top three reasons why a military connected individual states they do not stay in care is because they say their provider didn't understand them. So that's a huge area of opportunity for providers. Get that right.
Yeah, God, that's so important. I think even too within the military communities themselves, there's so many generational differences compared to, say, people in the military community, people who are in the military right now, just joining or in their like early 20s, people in our age group who are in their 50s who started out, serving in the Iraq War when it started, and then obviously are much older veterans. I see across that spectrum so many differences in how they access care, how they view mental health. That part to me is fascinating and tragic.
All in the same. I love that you bring up the generational differences, because even back to the beginning when I said, like, how are we designing the things that the solutions? That's one of the biggest questions I'll bring up is like, have you thought about what that 18 to 22 age range looks like right now anyways? Because a lot of these individuals were raised with a completely different language than you and I were. And one of them is empathy is taught at the core in schools now, which actually gives them a different level of
So
understanding of human
good.
beings than it did for us. I probably can't dive too much into this, but I was given an example of somebody who had the opportunity to interview some Marines after the Abbey Gate incident in Afghanistan. And one of the things that this individual took away after this moment was the empathy level of the Marines. He had never seen that before in Marines, right? And I started thinking about it. It's like, well, what's their age? Hey, we teach empathy in schools now. These Marines had an ability to have a different lens because that was to the core of who they were in their generation, really. And I think we miss that sometimes, right? We put our lens on it and we miss the strengths that they actually have. So yeah, it was one of those things that I think about a lot. I think generational differences are huge. And I'll just add one more thing to the PTSD, big misconception. We think it's all war related. PTSD in a military veteran, you better dig deep. It's developmental trauma over time
Yeah,
and it
layered with war trauma on top.
layered with more
So
trauma.
yes,
Yeah.
and that is so true. It all starts with adverse child events that really
Yeah.
kind of form that core trauma, and then everything else kind of piles on. And then you also said everything is not necessarily everything they're dealing with is trauma in the beginning. Let's
Yeah.
expand on that, because everyone's like,
Yeah.
veterans, we got to help their PTSD, but there's so much more.
There's so much more. And this is where I talk about like the social connection. I want to like always go from the strength base, obviously, but um, we are doing more in the suicide prevention space. So let's talk about some of those initiatives. One's, again, in which you've been brave enough to step in those rooms, which I'm always so grateful when we throw it at you and say, hey, will you show up? I absolutely love some of the larger initiatives that are out there. There's a huge thing called the Governor's Challenge. All of the states and territories are involved, tribes and territories. I think all of them have signed on now. And what it does is it brings in certain structural funding for states to identify what are their key priorities, their key, like, intercept mapping is done. They're doing mortality review boards, and community engagement with technical assistance. So each community or state can design it based on their community. You can imagine too how this defines even into tribes and territories. Tribes and territories do not use the same language that we do. So what I love is it's custom to your state approach. But what's coming up at every single table is this important thing around there's other things to well-being in a community, and that is suicide, especially since this is tackling you preventing suicide, money, financial stress, financial issues, relational issues, medical issues, pain. Pain is one of the top things that they're seeing, right? You talk about this all the time, like the disability claims related to suicides that have pain or some type of MSK, like disability rating. We're
Yeah.
missing that because we go right to this assumption that everything is around trauma, and it is relational, financial, physical, and physical are like around pain. And so there's efforts now that are doing things to address that so that there's the suicide prevention efforts that are embedded within different community members, not with just behavioral health or healthcare. One of the things you've helped me with is identifying too that your primary care doctor is, or your nurse practitioner, PA, is your first line of offense and defense to suicide prevention, because that's who they're coming to for everything, right? And so that behavioral health
Yeah.
screening or access to behavioral health within primary care is huge.
Yeah, and that's what we're so focused on, and it is hard. I think, when you talk about social isolation as a public health crisis, it goes so much more. It goes far beyond just the military, and I always say
Right.
social media is, we might as well call it lonely media, because it's just
Right.
isolating us further and polarizing us more. How do you feel like we can rebuild connection in this like very digitally fragmented world?
Yeah, I'm actually seeing some really great initiatives that have been built within the military community utilizing technology, but having really strong systems and research and evaluation so that they can tweak it fast. So there's a lot being done within the peer community, but peer community that can be accessible through tax checks. Wow, that sounds really good. Text chats and not having to have like really formalized check-in calls, but it could be quick and fast, but everything that's being evaluated so they can see if things are off mark, they'll adjust their applications. So there are some things that I am excited about. I think that the more that we are providing tech application to really respond through a peer lens, great results, seeing some really, really good results with that. I don't know if I can't say though, Georgine, I'm super sure on the social media front. I think from isolation in that same lens, the further people get isolated in their own social media channels. We also know that the military is a highly targeted area by outside actors to keep them more disconnected and believing in things that might not necessarily be true. I still am highly concerned in that area and not sure that we have enough strength around the acknowledgement that that's happening. So I think it's creating a further division, and that is scary. But in the positive place, I think some of the peer-to-peer models that are happening within our community are highly impressive, and they're working. They're peer-to-peer and they're also community-based, utilizing technology.
Let's talk a little bit more about what you just said. I didn't realize that. I mean, I feel like, obviously there's so much targeting of everybody in their own social demographic. Why is the military a more exceptional target? Do you feel, what, I mean, why is that happening? Where is it happening? What's it looking like? I hadn't heard that
Yeah.
before.
Yeah. So PsychArmor, again, we did have the opportunity to be a part of a collaborative. There's a great organization out there called We the Veterans, and at the beginning was led by a academic leader at the University of Maryland. Now I'm going to get this wrong, but it's University of Maryland. It was like through their counterterrorism work, and they have a huge military community there. And this is now 3.5, 4 years ago, the indicators of outside actors targeting the military to build this like unsafe environment for our military and veteran community was so worrisome that we were supported under a Department of Homeland Security grant to do education around that. So there could be targeted education to say, hey, this information's out there, it's real. Just like we do with our teens, be aware that you are being targeted, and this is why. So I would reference everyone to that if this is of interest. It's great. Take a look at We the Veterans and the initiatives they have, as well as University of Maryland, easy search. But there's a lot of other stuff out there. I have a colleague that runs his own journalism nonprofit because, again, local media, local journalism is really important. The War Horse is another great place. It's quite worrisome and should have more knowledge around it. I'm not the expert, but there's great people out there that are. And I think in the context of if I'm a military connected individual and I start to see my family members starting to get further disengaged and getting more polarized to family conversations, it should raise a red flag.
And what should people do in those situations? Oftentimes,
Yeah,
family members are kind of at a loss, and it kind of can go off a cliff very fast.
it can. We see this in the working with caregivers, in particular, caregivers that are really concerned around having at-risk safety items within their homes, right? So firearms is one of them. So at PsychArmor, we educate, right? So, and we always try to educate from the most positive perspective, like here's the data, here's what we need to know, and here are the resources. One of the things, since I'm going to guess you have a strong provider network that listens to this podcast, right?
Yeah.
There's exceptional work that had started at the McCain Institute, but it's now over at an organization called Eradicate Hate. And it was all started out of Pittsburgh after one of the synagogue mass shootings. And their whole thing is elevating conversations around some of these really significant areas of tragedy and what can we learn from them. So what you just said, they've had a military track for a long time and we, the veterans, have led it, which is how we got involved in the work. They have a very specific line of work called the Prevention Provider Network. And I find it to be really important for us as providers because I love their hashtag. And it's basically, you are not alone. And that means you are not alone as a provider. You see things, you know something might be going on, but where do you go? Doesn't fall on that line where it's ideation for intent and plan, of suicide, but it's like, I'm worried that this person might cause harm to someone else. Prevention Provider Network is built off of a Boston, can't remember what hospital model, but it's to help us as providers that as we start to see some of these things that we might be afraid, not that our person sitting in the chair next to us or across from us is actually in an area where they might hurt others. Here's some resources. Here's some groups. It's like a center of excellence, practitioners network that you can get support in those moments so that you know how to take that next step. It's really, really, it's pretty profound. It's good stuff. I wish more people knew about it because I've been in that seat where I have felt alone. And I have had those situations where unfortunately someone has done something that has harmed others or themselves. And it leaves you in a really really sad state at the end of that. It's hard to be in that position. And again,
Yeah.
military is not the only community, right? Happens to be the one that we know this data around.
Yeah. And we'll provide all these links in the show notes, but this is so helpful. Let's talk a little bit about the caregivers, the military dependents, and their families that sometimes get forgotten in all of these
Yeah.
conversations, but are so, so key to the equation. So I'll just
Yeah.
leave that open.
Yeah, so I think on that, like again, like from a prevention lenses, your family member is the one who's actually going to be the person who, if our focus, let's say in our initiative, in our practice, in the system that we deliver care is that we want to support the active duty guard reserve, or we want to support a veteran client. Guess what? Get to know the family member, because they're the ones who's actually going to walk them through the door. And so if you're not focusing on the family as well, you're really once again missing the mark. Understanding that the pay system might require something, but I always look at outreach strategies to say, do you allow the mama to make the phone call? Because some of the biggest things might be that mom back in rural, somewhere says, my son or daughter just returned back from home. There's something that's different. I don't know what to do. And if you're calling the VA, that could look like have the veteran call them yourself, right? And nothing's
Yep.
left for that individual. So there have been a lot of initiatives and a lot of different things that have been built. The Elizabeth Dole Foundation has built out Campaign for Inclusive Care, which is insular to the VA, but it's given a large voice to say that caregiver needs to be sitting at the table with you. They need to be in the room because they're going to be a really good source of information of what's really going on. I think from a community perspective, my request and something that you've been involved in is, if providing programs and services, invite the entire family system to the table. Because if the family member is not invited, it's going to be much harder to get the military person through the door.
Yeah, no, I see that all the time, not just for military communities, but across the board. There are families are and our support networks are who are sometimes carrying the load and can make the difference. And if they're shut out, it closes down the entire conversation. For practices like ours that integrate therapies like TMS, primary care, and behavioral health together, how should we think about community in addition to treatment?
Yeah. Well, I'm going to use you as an example. Is that okay? Because I think
Sure.
I think this is the perfect one. So again, you could have just hung up the shingles and said, "Hey, this is really great. I think that I could provide a wonderful service to this community." But I think each community, and again, well, just military community, they need to build trust with you. And the only way that they're going to build trust is that you're actually in their community, or you're building trust within the people that they already have established trust networks. And that's why I love social network theory, is because even back to isolation, penetrating somebody's network so that they're very, like, we have super strong ties. You're within my super strong tie. I know you, I trust you. You tell me to go somewhere, I'm going to go there because I trust you. The power of your network is actually in your second and third referral, which is a weak network to me, but I'm going to trust it because you sent me there. And that person, right, really might be able to create that change. So what I love about our initial conversations is I said, yeah, I think Dr. Nanos, what you have to provide is great, but you got to get in the community. And you did. You spent time, resources, and energy in getting to know the veteran support or military support organizations, so that as they were working with that military member or even family member, because you put it as an all encompassing, you said, I want you to know that we're here for you. You can refer them to me and trust that I'm going to take care of them. Right. And
Yeah.
that is key. Like, that is key. It's not about delivering the service first. It's about building the trust within the network of support so that they'll get them through. And what do we used to call this? The warm handoff. It's much more than a warm handoff. Because I think if you would have tracked it, maybe you did, how many hours over at least that first 2 years of targeted and a staff member that I know that you put out in the community, you had to be in multiple places. And that was time, energy, and resource that had no billing to you. But if you didn't
Yeah.
do that, it was going to be harder to get them through the door.
Yeah, absolutely. So how do you think so you let's talk about being a let's talk about leadership of PsychArmor, leader your role as the CEO and your
Yeah.
leadership style and how that's evolved and the challenges that brings and all that good stuff.
Yeah. One of those things I think that I love about the things I've learned from you is also thinking about, well, leadership across our own transition points. So even within like looking at those places where we get isolated, it really is in those transition points in our life. And so some of that is like really hard transition points in your 40s and 50s. And we think it's because, oh, okay, I got the kids, or I'm going through a divorce, I got this. Really, there's something huge that's going on biologically, and we're not paying attention to that. So I do love the focus that we're starting to place into where's our health during these really intense times that we're leading things. So I don't want to like miss that as a mark, because I think if I only talked about, oh, this has been, these challenges and these, when my body wasn't right, that made it 10 times harder to be leading. And once I was able to start to really focus in on how's my body transitioning through different things, I could actually then be a better leader. So tab that to all your podcasts around hormone health, because it's so necessary, so necessary. And it's also those key points where military members are transitioning. They transition from their 40s and their 50s, typically, if they've had a lifelong of service, and they're transitioning at a point where things are changing and yet they're in a pressure zone. So tab that over there.
Yeah.
Holy hell, heck, leading an organization as you do, it has really been interesting over the last several years. I think leading a team that is now demanding to be hybrid or completely remote for me is no bueno. That's really, really been hard. I'm jealous of you to be in the office. And I think meeting the demands of a workforce in the way that they need work to be for them has made leading very complex. On another note, what I'm very grateful for is having opportunities to expand and have support in fellowship programs. Like going to the Bush program was huge, because it was for the first time someone actually pulled the chair out, put my name at the table, and said, we're here to make sure that you're strong in your leadership moving forward. And that's been incredible. And also, when you're exposed to something at such a magnified level, like a presidential institute, it reminds you your problems are actually not that big. Keeps that going. Yeah, keeps it going. So I think, in leadership, it's important to always be learning. And if I hadn't had those critical things, and learning again is learning from you in those places too, where I needed to understand what was happening to me transitioning within my own physical health to be able to keep up with the demands of the job.
That is such an excellent point about our physical transitions, especially as women. We tend to hit our career strides in our late 40s and 50s, and that is when so many things are just kind of becoming more complex within our own bodies.
Yep.
So thank you for acknowledging that. Getting back to the transitions, and transitioning out of the military, and I see this so often, and not just ending a long a 20-year or 20 plus year military career, but even when people are retiring, those life transitions are so challenging for so many patients, almost universally. But
Yeah.
I see it particularly hit men a little bit harder than it hits women. Let's kind of dive into that a little bit, because I think people underestimate the toll it takes on them, and trying to find their footing. My
Yeah.
my hypothesis for the military community is, I think it's especially hard for them because the intense structure and rigidity of the military gives them this really tight framework that they kind of have to walk through their whole life, and then when they're out, it's like, whoa, like now I can do anything, and it's overwhelming for so many people.
Yeah. Well, and I wonder how much, I used to think, oh, we slept these words on there to define it, but it really, I hear it over and over and over again: purpose and identity, purpose and identity. So you came from a very an institution that had high purpose. You knew exactly why you were there. Even if you disagreed with it or whatever, you knew why you were there. You knew
Yeah.
what your purpose was. You knew what your identity was. Once again, even if you disagreed with your identity based on rank or job or whatever, but you knew what it was. Came from a highly structured environment, like you said. And then what does it look like in the civilian world? Not to knock the civilian world, but we're not as rigid. And, when we work with employers at PsychArmor, we'll do just culture training, and we'll do like hiring strategies, recruiting, hiring, and retaining. And on that retaining piece, something that's come up time and time again is you'll focus to say, well, we want to bring in a military talent, but they get here and we just don't understand them. Maybe the reverse is they might be telling you have a culture problem because they understand what it means to come from a place where your mission and vision is highly defined. And a lot of times we don't have that in our organizations. I've seen that just We have a team that's military connected. Their spouses or their veterans, or their veterans. The biggest feedback they'll give me is like, what's the commander's intent? I'm like, well, go do your job. No, that's not what they mean by commander's intent, right? So sometimes that misalignment because they came from that. But I do think this new, what is your purpose? Do you have a purpose in your day to day? And what's your new identity? And if we don't spend any time in helping somebody, whether they're military or not, and or they define that for themselves, it can be like, where's your compass then? What are you doing? But I did feel that as a military spouse too. Even as we transitioned from one community to the next, redefining yourself. Did I ever feel like I was in the shadows? Did I not? Did the community want us there? Did they not? There's always this thing where you're constantly having to be a chameleon. So, yeah, I think those transition points can be very, very difficult.
Yeah, you're right. It is all about that purpose and identity, and just finding that, which can be a struggle. So what's giving you some hope right now? Let's go back to the positive.
Yeah, the positive. Well, I think when I look at being a leader in the nonprofit community for, my gosh, not joking, like over 20 years now, we still have a country and a community that supports the military connected community. That's important. It's really when I came on the scene of this nonprofit world, there's like over 45,000 nonprofits. There's this whole thing like we have this like saturated community. No, like for a population that at one point did not have a large nonprofit community supporting it, we do now. And so we have systems in place that support families and caregivers and military, and that needs to stay. That needs to stay. It needs to stay well supported. And so I think that there is a great ecosystem supporting our military connected community, and it's still being invested in. I think there's challenges with everything, but this country has identified, at least in its philanthropy and its support system, and even down to in healthcare, that there is a need to understand our military community and there's a purpose in serving them. That I'm glad about. Like we haven't fallen off of the popular track, right? So that's good. And I think I've been saying this for several years, and maybe I'm highly influenced by our Governor's Challenge work. Communities are doing exceptional work. And San Diego County has some really great coalitions. They have a lot of great efforts here. What I'm loving seeing is that there's starting to be this immersion. So we can say, and you've mentioned it several times, your military community is really just a small little microcosm of the larger community, and the intersectionality of everything is there. Might there be an opportunity for all of us to support one another in our efforts? Like I might specialize in military community, but when I'm working on suicide prevention efforts, it should expand to a broader community. Hey, I've perfected this over here. Let me share it with the rest of the community instead of being so hyper focused on one particular population. If that allows for expansion, I think it's a great thing. So that's from the philanthropic side of the house. The other thing that I'm super excited about is in the line of work that you're doing. So I think that the opportunity to expand what are the different types of places that we can find health and well-being and really truly health and well-being and slash performance is happening through veteran leadership. And TMS, the work you're doing, is at the top of the things that get to be talked about. So MCon Health, which I hope that you'll partner with us on next year, brought people together that were working in the world of psychedelics. We're working in the world of performance. We're working in the world of gene expression. That's why you need to be there for TMS. All
I'm
of
gonna be there.
that.
Is it
Yeah,
this
we
year or
need to.
next year?
It'll be October. It'll be October. Yeah.
Okay.
Your friend Waco, you and Waco, we
Yes.
got to get the two of you, we got to get the two of you back together again. Waco Hoover with MCon. But I love that what we purposely did was we talked about a high performing community that wants to stay high performing. So if we know that there's all these places where there could be fractures, how do we circumvent that? And so I think from that place of, even TMS might come to it at a point where we're really in this like need zone, but I think you're helping me understand too, it's a maintenance zone, right? Like there's
Yeah.
maintenance that can occur. So I love that. And I do think, thanks to all the stuff that's out there, we're getting to this other side of maintaining and or having an opportunity to really influence our own health versus a system tell us how we have to receive it. And that's inspiring. And you're leading that.
Thank you. Yeah, I do feel like we're getting closer to that inflection point where
Yeah.
we can be more collaborative and less siloed, if you will. What Okay, if you can change one thing in our current mental health ecosystem, what would it be?
Insurance.
Kill it. Kill the beast. That was
Well,
great.
again,
That was a great
no, like
response.
Georgine, I mean, seriously, like, this is the other thing that is just like really irritating me right now is when you see the headlines that we do not take care of our military connected community. I sit with a list of social workers in particular that have built practices and have done everything they were supposed to do to be able to open their doors, and they're not getting paid for seeing their clients. So then they have
Yeah.
to go to cash pay, and then no one can afford it. We're talking about the wrong thing. The insurance paying system is defunct, it's wrong,
Yep.
and it's holding people from care.
100%. That is 100% accurate. Yeah, I live it. I see it every day. It is the biggest tragedy in this country in terms of
Yep.
healthcare, hands down. I agree.
Yeah.
How do we dismantle it?
Yeah. I was gonna say, was that like too easy?
Yeah. No, but it's simple and complex at the same time. It's just yeah, it's just it ruins literally ruins everything for doctors and for patients. We are all trapped inside of it, and it's not serving anyone but the pockets of the insurance company, unfortunately. Um
Yeah.
okay, let's get a little more positive.
Well, but
So
let's okay,
depressing.
here's the positive spin to this is to name it. Because if we name it, maybe we can take the responsibility that often sits on our shoulders as providers that we're not doing enough for a community. You could be changing lives every single day if patients had access to your care. But
Yeah.
they're being right. So I think in naming it says we have solutions there. There is one major barrier. And unless we're willing to look at that, but I don't want that narrative to be there. The other line of it is we talk so often about not that there's not enough mental health professionals that are trained. That's part of my narrative. But on the flip side, I want to say, I know an entire workforce of mental health social workers in particular that would love to work with the military. They don't know how to get into that system. It's extremely
Yeah.
complex to become a social worker as a GS person, right? And it's extremely hard to write a resume. So, might we also look at how are we developing a workforce that's going to be supporting this population? We could do better on that too. So, on the positives, it might be naming it and really then tackling that problem instead of saying us as providers that we're not doing enough for a population. I'm not willing to carry that anymore.
Yeah, no, that's true. I completely agree. This blame on the providers and the healthcare
Yeah.
system is, I mean, the people that within the healthcare system are genuinely, for the most part, wanting to do good, and again, just kind of completely shackled to the constraints of the insurance
Yeah.
world. Ugh,
Yeah.
gross. I hate
Yeah.
it.
Yeah. But we named it. Okay. So there's the positive one. So
Okay,
yeah, everyone,
so
let's
that's
just,
good.
yeah.
All right. Let's talk about, let's see. Let's talk about how our listeners can get more involved or learn more. What we've got. So we have a lot of listeners in just the general public, and then we have a lot of providers, healthcare providers, clinicians across the board. What are some things that people can do if they want to help the veteran community? That's a very general
Yeah.
question.
Yeah, and I'm not necessarily here to push PsychArmor for sure because there's no pushing, like right, we're a nonprofit, but our purpose is to bring evidence informed, trauma informed education to our provider community is like our number one focus. It's where we were founded here in San Diego by an LMFT. It's where we continue to have our efforts. And so what we recently did is we made our veteran ready certificate online and available for users to go in. There's a slightly little bit of fee. We had to do that because we're training people. So, and we don't have philanthropy supporting it anymore, but it's minimal. And what it will do is give people that baseline to start with, like, what are the basics that I need to know when serving a military connected community? Then from there, we have everything on our website you can take anytime, anywhere for free to include an entire track for healthcare providers to include also an entire track around suicide prevention, utilizing techniques for healthcare providers, I guess. And it does not just have to translate to our military community. That just happens to be the cultural lens that we have in our courses. CMEs, CEUs, get your stuff over there if you'd like. So that's easy. Like I can say that for health and behavioral health providers. I think the other trickier thing is just not getting overwhelmed by this larger conversation that we aren't doing enough. I think that there are some really simple things that we can do. And some of it is just recognizing that there is this unique population that you're serving and identifying who they are by starting to keep track of it within your own internal systems. So you can start to say, yeah, I have a veteran population I never even thought I did. So So there's a lot of places that aren't even tracking that metric, and that metric would be really valuable down the road in some of the ways that you deliver service. So those are just some of my two favorite ones.
Let's close on a little rapid fire segment. One word that defines leadership.
Trust.
Okay, community means blank.
Everyone.
Innovation requires blank.
Human-centered design.
The future of mental health is
Non-restrictive.
Dr. Atherall. Thank you so much for your leadership and for reminding us that healing doesn't happen in isolation. It happens in community. So if you'd like to learn more about PsychArmor and the incredible work being done for military-connected communities, visit psycharmor.org and connect with Dr. Tina Atherall on LinkedIn. And as always, thank you for listening to The Kind Revolution. If this episode resonated with you, please share it with someone who believes that community is medicine and that innovation and compassion belong in the same conversation. Thank you again. And thank you, Tina.
Yay. Thank you.
Thanks for joining The Kind Revolution. If this gave you something real, hope, perspective, or a fresh way to think about health, please share it, subscribe, and pass it on. Medicine won't change on its own, but together we can reimagine it and build something smarter, kinder, and create a system that truly heals. This is The Kind Revolution with Dr. Nanos, where science meets compassion and the future of medicine gets brighter one conversation at a time. Thanks for joining the revolution.